Welcome to the Sleep World Magazine product demo live. I'm your host, Michael DiDomenico, publisher of Sleep World Magazine. Thank you for joining us today. Where leading sleep companies present their latest products and services. First up, it'll be Persante, then Noctrix, and then Dormotech. So we've got a bunch of different things going here. After each presentation, we'll give away three $50 Amazon gift cards. We'll draw those at random from attendees. I'm going to draw those while they're speaking. And then after each one, after we're totally done, we're going to give away one free registration to the Philadelphia Sleep Conference. We want this to be as interactive as possible and as fun as possible to make sure you put your questions in the Q&A section. Q&A, not chat. Q&A, please. Feel free to hit the emoji buttons, use chat to communicate with other attendees, drop messages in there. We'll put those up on screen, and you can go, all the links you'll see on screen while these guys are presenting today. All those, or most of those, are going to be hot links. So you can go right to their websites while we're doing this. And let's kick this thing off. Whitney Brenke is the Chief Operating Officer at Persante Healthcare with more than 13 years of leadership experience in sleep medicine operations, beginning her career as a RRT and an RPSGT. Whitney has helped develop, scale, and operationally support a wide range of sleep programs, from independent labs and correctional systems to hospitals and large multi-site healthcare organizations. Please welcome Whitney Brenke.
Thank you, Michael. As Michael said, I'm Whitney Brenke, the Chief Operating Officer at Persante, and I appreciate the opportunity today to speak to you all about an issue that is becoming more increasingly important across healthcare systems. So, how sleep medicine is organized, supported, and sustained over time. As Michael said, my background is rooted as an RRT, RPSGT, and over the past 15 years, I've had the opportunity to work across a range of healthcare systems, including correctional systems, hospitals, and large multi-site healthcare networks. That broad experience gave me a practical view of what actually helps a program succeed, what creates friction, and what it takes to build something that can truly scale. I want to spend just a moment on that experience because it really shaped how I think about operational design. Working in correctional systems gave me a foundation in structure, consistency, and the importance of building processes that work in highly controlled environments. Expanding this perspective into hospitals and large multi-site systems reinforced an important lesson. Each environment has its own demands, but the fundamentals remain the same. The program must be reliable, the workflow must be clear, and the model has to be adaptable enough to support both quality and scale. What we are seeing today is that sleep medicine is no longer functioning as a standalone service. It is increasingly connected to cardiology, pulmonary care, chronic disease management, broader patient outcomes. As this happens, hospitals are no longer asking a direct set of questions. They are no longer asking, how do we just complete more studies? They are asking, how do we build programs that are integrated, efficient, and aligned with a complete patient pathway? That shift is really the foundation of today's discussion. The next issue is the pressure point that hospital sleep programs are facing right now. They're going through workforce strain, growing demand, and the need to scale in a more connected way. It also shows that sleep medicine is no longer operating in isolation in the hospital. Across the country, hospital sleep programs are under more pressure than ever. Demand's increasing, patient complexity is rising, workforce shortages continue to affect nearly every part of operations. At the same time, expectations around integration, turnaround time, visibility, and patient follow-through are also moving very quickly. In many health systems, the challenge is not a lack of commitment. It is that programs are often being asked to grow, on top of workflows and infrastructure that were originally built for a smaller environment. When this happens, even well run programs can feel the strain. Scheduling becomes harder, communication becomes less consistent, visibility across the patient pathway becomes limited. The larger point here is that sleep medicine is becoming part of a broader enterprise strategy. That means it now has implications for downstream specialties, patient retention, and long-term clinical value. So the real question here is not simply whether demand exists. The question is whether the infrastructure behind the program has evolved at the same pace as the demand itself. The next question is what happens after diagnosis? Where the pathway leads matters. It affects follow-up, coordination, and the hospital's ability to maintain visibility across the patient journey. In fragmented models, once a patient moves outside the system, hospitals often lose most of the picture. Testing may still happen externally, but coordination will become disconnected. Follow-up is going to be harder to track. And over time, that creates gaps not only in operations, but in referral alignment and long-term patient retention. By contrast, hospital-aligned models are designed to preserve visibility and strengthen coordination across departments and specialties. They help maintain oversight as the patient's needs become more complex. That is why this is not just an operational issue, it's a strategic issue. The pathway a patient follows often determines where long-term value stays. When hospitals have a clear view of the full patient journey, they are better positioned to support care, maintain referral strength, and protect downstream value. That is one of the reasons the conversation around sleep medicine is changing. It is no longer about testing. It's owning the pathway. This brings us to infrastructure, which has become one of the most important factors in program performance. Today, sleep programs depend on much more than diagnostics alone. They depend on how well the surrounding operational ecosystem is connected. Visibility, workflow continuity, automation, EMR integration, scalability, all influence how effective a program can operate and grow. When those pieces are disconnected, friction quickly builds. Communication will slow down, reporting will be inconsistent, scheduling gaps are more difficult to manage. In this type of environment, even strong teams can spend more time reacting to the problems than improving the problems. When infrastructure is connected, the experience is very different. Hospitals will gain visibility, more consistent workflows, and a stronger foundation for growth. That is why many organizations today are taking a closer look at whether the structure supporting their sleep program is actually built for the future they want to create. This matters because infrastructure is not just a back-end issue. It directly influences the patient experience, the internal team experience, and the organization's ability to scale responsibly over time. One thing we see consistently is no two sleep programs operate the same way. Every organization has its own population, referral patterns, staffing realities, growth goals, and operational constraints. Some are focused on HST pathways, others are rebuilding in-lab capacity, and some are trying to support multi-sites across a large healthcare system. Some are trying to improve coordination between sleep medicine and downstream specialties. Because of that, modern sleep programs need flexibility, they need integration, they need scalability. They need operational models that can adapt to the realities of the organization rather than forcing the organization into a rigid structure. That distinction matters. Success in sleep medicine is not only about volume, It's about whether the program is built in a way that can continue to evolve with the health system over time. In practice, that means looking at the program as a connected operation, not just a diagnostic service. It means aligning clinical operations, infrastructure, program performance, patient coordination in a way that supports the facility's quality and growth. When health systems take this approach, they are better able to build a model that reflects how they actually work rather than trying to make the organization fit a structure that it was never designed for. This is where Persante has intentionally positioned itself differently. We are built around hospital sleep medicine, and we partner with hospitals nationally to create customizable operational models based on the needs of each organization. That flexibility is critical because operational challenges do not look the same. Some programs need workforce stabilization, staffing support. Others, they need better technology, they need better reporting. Some are focused on scaling HSTs while trying to maintain coordination across the patient pathway. Others, they're managing multi-site growth or working just to standardize workflows across departments and facilities. Our role is to build around those realities, not force a fixed structure onto every organization. This includes support with diagnostics, scheduling, staffing, compliance, integration, and ultimately long-term operational oversight. And because Persante supports more than 300 facilities across more than 25 states, we have had the opportunity to see how different organizations approach growth, scalability, and operational alignment across all different healthcare environments. At the end of the day, facilities need more than testing. They need a model that is practical, adaptable, and built to support continuity over time. When a program is aligned operationally, the impact becomes measurable. We see improvement in turnaround times, stronger workflow consistency, better patient completion. Those changes matter because they affect the day-to-day experience of the team and the long-term performance of the program. In many cases, hospitals can improve throughput and operational performance without having to rebuild everything from the ground up. That is important because most organizations are not looking for disruption. They are looking for better structure, clear processes, and a model that supports the work they are already trying to do. The strongest programs today are not isolated diagnostic services. They are connected operations that support broader goals, stronger retention, more sustainable performance. That's where the value becomes visible. The future of sleep medicine will belong to hospitals that maintain visibility, coordination, and ownership across the patient pathway. The programs that will succeed will be the ones built on integration, adaptability, and long-term alignment. This matters. Sleep medicine is becoming more connected to the broader healthcare ecosystem every year. Hospitals are increasingly recognizing that if they want scalable programs, they have to have scalable operational models supporting them. Thank you again for joining me today. I appreciate the opportunity to share my perspective and what I've done, and I look forward to the conversation that follows. Thank you, Michael.
You're welcome. Great messaging. You know, your experience really comes through here. We've got time for just a question or two. Persante, this is from Robin Woike. Persante, are you integrating the sleep navigator role into the Persante operations?
We do. So to answer that, we do have some partners that use sleep navigators. I do believe they're important. They're helping us move those patients from start to finish, get them to the end. But not only that, what I just presented on the patient pathway, complete integration and following the patient from testing to treatment and follow-up care, and then even more what comes after that. Staying connected, using the navigator for that role.
Awesome. One more quick question. We're going to keep right on schedule. Um, what separates a fragmented sleep program from a truly hospital aligned operational model? I think that's a really important question.
I would say a fragmented sleep program tends to rely on individual workarounds, uneven handoffs, inconsistent scheduling. So, fragmented is like performance depends on who's on duty that day, who's working that day. A more hospital aligned operational model is different. So, we'll use standardized workflows, define responsibilities, transparent reporting, integrating the systems. In practice, that would mean the program would support referring physicians, patient access, hospital oversight without forcing constant reinvention of the wheel each time. So I've learned fragmented versus aligned through my years of experience and mostly in the corrections world. So you can imagine operating that many facilities and each of them are different, but you still have to have very clear operations, workflows, and it's all standardized to that
And that's
facility.
and that's
Not
what you guys specialize in.
absolutely.
Contact us at Persante.com is up on the screen. You can click on that now. You guys can reach out to Whitney Brenke at Persante and her team. You'll be at Sleep 2026. We appreciate that. You're also going to be, well, you can't see it right now because of the screen size, but you guys are in the upcoming issue of Sleep World magazine. I would look forward to seeing you in Baltimore. We're going to pick right now. We're going to pick I already picked the 3 winners from Persante, the 3 $50 Amazon gift cards. Neil Allen, you are a winner. Sheena Fields, you are number 2. And Terry Dawn Bourdette,
Oh,
you are
yeah.
number 3 from Persante. We will email those to you guys. You can put a little message in chat too to say that you heard that and you got that. And thanks, Whitney.
Thanks, Michael, for having me.
All right. Let's bring up Matt Ziegler. We'll take Whitney off. There he is, handsome as ever. Look at him.
Oh boy.
You are next up. Let me read your intro here. I've got it in one of these screens, I'm sure somewhere. Hang on one sec.
As you're pulling that up, Michael, let's give it up for Whitney and Persante. Great presentation. Well done.
Yeah,
Whitney. That was
she
fantastic.
did great. She was chewing at her nails when I brought her on screen, but she did a great job. Matt, you're going to be a natural. Matt Ziegler is a med tech marketing executive who specializes in commercialization strategy for innovative medical technologies. For the past several years, he and the Noctrix Health team have been reshaping the landscape of RLS care with a first-in-class breakthrough device. I actually really like this device. I'd like to get my hands on this device because I have restless legs. But let's hear it from the professional. I'm going to bring up your presentation. There we go. I'm going to disappear. If you need me, I'll be here. I'll see you on the other side.
Perfect. Thanks, Michael. And anybody who does want to get their hands on the technology, we will be at the Sleep Conference coming up here. So definitely swing by the booth. Also, good to see some familiar faces. I think we have JT on here, Lori, some friends of the family. So really excited to be on presenting today. Obviously, Michael and I have limited time here, so we're going to keep it really high level. If you do have additional questions, please don't hesitate to reach out. I think at some point, Michael's going to throw up our website on the page there, and you can click into that. Feel free to submit any questions or just reach out to myself, or like I said, swing by Sleep this year. Going to be an exciting conference, and so happy to meet and discuss Nidra with all of you. So that's why we're here today. So discussing our Nidra device. Before actually getting into Nidra, I always find it's helpful to actually first identify the unmet need. So what is it that we're actually talking about here? Restless leg syndrome. I think for any of us in the sleep space, we all know that this is a very underserved population and, very often misunderstood condition. So some high-level stats that I think are helpful to start with here. 1 in 10 people in the US suffer from RLS. So odds are many of us know somebody that's either living with the condition or are affected by it. That might be a caregiver or another friend or family member that has it. Limited drug-free, effective RLS treatment options. We'll also get into some of the existing treatment options that are, in the pharmaceutical category, like dopaminergics, opioids, which obviously have their own challenges. And then that final stat there, 50 to 70% of patients on the leading prescription medication are still experiencing worsening symptoms. So any of those familiar with augmentation, it's still a massive challenge within this population. So Nidra really is the first and only wearable device that is clinically proven to reduce RLS symptoms and improve sleep quality. We'll get into some of the studies and publications that we have in this presentation, but again, for a much deeper dive, swing by the sleep conference or reach out and ask some additional questions. So when it comes to what the technology actually is, here's a basic slide that walks through what we're actually talking about. It's two rechargeable bands that are worn just below the knee. Ultimately, these are stimulating the peroneal nerve. So that's a nerve that runs close to the surface of your skin, right to the outside of your knee. What it's actually doing is delivering stimulation via what we call tonic motor activation. So this is a first-in-class technology, different from other stimulation technologies that are out there. And in the next slide, we'll actually get into what actually makes this different. And so it's delivered at the onset of symptoms. So it's not a prophylactic. It can be used day or night, but typically during periods of rest. So most patients will actually apply the bands before going to bed. And as soon as they start to experience symptoms, they'll simply activate the device. Once they activate the device, it runs for 30 minutes with an automatic shutoff. So most patients, when they're delivering therapy, they'll actually go to sleep. They can run multiple therapy sessions in a day. So if they still have symptoms after that initial 30 minutes, they simply activate the device again, and it turns on for another 30 minutes of therapy. Each device is personalized to the unique needs of the patient. So what we do is we provide what we call a personalized activation session, in which we, of course, train the patient how to use the device, but also identify their key therapeutic levels and then program the device with 5 different ranges. So depending on symptom severity, they can increase the amount of stimulation or actually decrease the amount of stimulation. So rolling right into, how does this thing actually work? What is it doing? I mentioned TOMAC, so tonic motor activation. What is this doing? So it's stimulating that peroneal nerve, but the key differentiator here is what you see on screen, that high frequency. So actually operating at about 4,000 hertz. What this allows TOMAC to do is actually stimulate the correct nerve fibers. I'm sure a lot of you are familiar with something like a TENS unit, where that's really, really low frequency. So typically less than 150 hertz, where that's really trying to disrupt those pain signals. And so those pain receptors closer to the surface of the skin, that's what the TENS unit is actually attacking. Whereas here, we're bypassing all of those pain receptors, because one of the key criteria for this device to be effective is it needs to be comfortable to sleep with. So it needs to actually activate that relief pathway, but also allow the patient to actually go to sleep to improve that sleep quality. And ultimately, I think on the inside here, what we typically like to say is it's actually almost tricking your brain into thinking that your legs are walking. So we're tapping into that motor pathway in order to activate that RLS symptom relief. So some scientific, words down on the bottom right there, but effectively what we're doing is stimulating that peroneal nerve, activating, that tibialis anterior muscle, and then ultimately tapping into that RLS relief pathway. So when it comes to the high-level takeaways from our growing body of clinical evidence, which you can see at the top there, we now have 10 peer-reviewed publications. So very, very excited. Big shout out to our clinical research team, and even JT, who's on the call today here. He's been instrumental, in the last, 4 or 5 years, getting this growing body of clinical evidence for us. But 91% of our patients experiencing symptom relief. So that's the big statistic we like to lead and promote with. But you'll also see 82% of patients, get relief after just that first 30-minute session. And then a statistic that's also interesting, we didn't anticipate, was that 2.72 fewer days each week with RLS symptoms. So what this is actually, showcasing is a reduction in symptom frequency over time. So after the period of our extension trial, patients who had originally started the trials having symptoms 6 days of the week, they, by the end of the extension study, were actually only experiencing symptoms 3 days out of the week. So they were actually having to use the device less over the course of the trial. Very exciting to see. And then, of course, that final stat there, no medication-related side effects. So this is when one of the key challenges of this patient population, not having any effective drug-free options. So we are very excited to be able to finally offer, this struggling patient population with a drug-free solution that actually, will attack those RLS symptoms and not also come along with those catastrophic side effects. So again, I wanted to keep this really short and to the point because again, we can go down so many different rabbit holes here. I'll throw up overall contraindications, adverse events, just so everybody has visibility here. I think one of the key takeaways is that when it comes to active medical devices, that's one of the key contraindications that we do have with the device. But that being said, I guess, Michael, I did want to save plenty of time for questions because the technology itself is pretty straightforward once you fully understand and appreciate how it's different from other technologies. So let's go ahead and open it up to questions so we can actually get into the good stuff.
Yeah. So I wanted to know, what's it feel like when you wear it? Like, i- is it just vibrate, or is it like, what is it?
Great question. So, gosh, patients and a lot of our HCPs will actually feel the device too. They report different sensations. A lot of what I have heard is a buzzing or a tingling. And once you actually reach what you call the distraction threshold, so that's when you're actually getting the benefit of Tomac, you
Right.
can feel it almost radiating down that muscle in the front of your shin, that tibialis anterior muscle. So it is almost this massaging, buzzing sensation. And for anybody who would actually like to feel what Tomac feels like, swing by the booth at Sleep if you'll be there, because we do what we call sensation demos. And so, I think a lot of
Sounds
providers,
sensational.
it does. It is sensational. It's a huge draw, Michael. I'm excited to strap you in and let you experience it.
I want to. I'll be over.
Perfect. Yeah, because I think one of the big questions we often get is, hey, does it feel like a TENS unit? And it's very, very different in the sensation. TENS unit being that intense kind of throbbing
Yeah.
sensation, whereas this is more of almost like a buzzing tingling that's constant and doesn't have that wave of energy that comes
Cool.
through.
I definitely will check it out. Here's a question from Aaron Diaz. Are there certain prescribing guidelines that need to be met prior to ordering the Nidra, such as patient being required to try a different therapy first? And that is part of it, right? This is a refractionary.
Correct. Yes. So the indication for Tomac in Nidra therapy is primary moderate to severe RLS. So that's the first requirement, and it is for drug refractory patients. Now, important for everybody to understand, refractory can mean a lot of different things depending on the class of drug through the lens of the FDA. Within the context of Nidra therapy, the FDA gave us very clear guidelines that is simply the patient has tried a medication and they are still struggling with RLS. So they don't have to try multiple medications. They don't need to ultimately fail a drug going to the
Okay.
highest dosage. It's really they've tried, let's say they're on the lowest dose of Mirapex and they're still struggling with symptoms. That would be a patient who is indicated for Nidra therapy. Great
Good.
question.
How is it different from tens? Asks Dinesh Kumar.
Hey, so great question. So it really is that high frequency. And me being the marketing guy, the way that I like to think about it is precision nerve fiber targeting. So what we're actually doing is we are bypassing those pain receptors. That's what a TENS unit is actively going after, so it can disrupt that pain signal. Whereas that 4,000 hertz is actually going much deeper and bypassing those pain receptors to specifically target the fibers of that peroneal nerve. So it's the key difference is that 4,000 hertz, that very high frequency, as opposed to about 150 hertz that a traditional TENS unit is typically operating at. But also, that's a question we get quite a bit, that our medical affairs team, if you really want to go the deeper dive, can definitely put everybody in touch with the medical affairs operations. And they love talking about TENS versus TOMAC.
We're going to end with one quick question here. And I think it really is like, if you're going to Sleep 2026 in Baltimore, this is, the way to answer those questions is to try it out and see how it feels, to really understand it. This question from Nazneen Sultana: does sometimes RLS is associated with PLMs? Is it helping to treat PLMs as well?
Hey, good question. I'd probably have to actually kick that one to the medical affairs team on our end.
Okay.
We are only indicated for use in that primary moderate to severe RLS.
Yep.
So when it does come to PLMD and other movement-related disorders, we don't have any clinical studies on that front. And frankly, I'm just not as close to the ongoing clinical research that we have today to give the kind of answer that I would want to give on this one, Michael. But again,
Yep.
more than happy to connect them with the medical affairs team to take that deeper dive, because we are exploring other conditions and where this device and this technology could have additional applications as well.
Due to time today, we're going to move on, Matt. I appreciate you being here. We've got actually several questions in here for you. How can people reach you, or what's the best way to reach out to get their questions answered? And we'll send you these questions, Matt, as well. But is there an easy way for them to do that?
I'll actually drop in the chat our email that
Okay.
everybody can reach out directly to me, and I'll try and get their questions to the right individual. For any providers on the call, the best plan of attack would be go to the website, and on our provider section, fill out the form, and that'll connect you directly with your local rep. And that'll be the most effective way to get everything that you need in order to learn about the technology and ultimately prescribe. But like I said, Michael, I'll drop in the chat my contact
Good.
info so everybody can reach directly out to me. And whether it's a medical affairs question or just a simple onboarding or technology question, I'll make sure it gets to the right person.
Great, Matt. Excellent presentation. See you in a few weeks.
Sounds
Thanks
good.
for being here.
Take
All
care,
right,
Michael.
bye.
Bye, guys.
All right, we're moving on. Next up, we'll take Matt off here, and we're going to bring up Sar.
Hi, Michael.
How are you, Sar?
Great. How
Good
are
to see you.
Good to be
Good
here.
to have you here. Let me do your intro, and then we'll dive into your presentation. With a background spanning neuroscience, sleep research, EEG analysis, and neurodegeneration, today's presenter, Sar Lanner Azaria, scientific expert and customer success lead at Dormotech, brings a unique perspective to the intersection of clinical science and medtech innovation at her academic work at the Hebrew University of Jerusalem, Weizmann Institute of Science, and a PhD from Tel Aviv University focused on uncovering neural mechanisms related to sleep, motor learning, and Parkinson's disease. Please welcome Sar. How are you today?
Great to be here. Thank you for the
Good
opportunity.
to have you.
Yeah.
Let's bring up your presentation, which I know you just snuck in there, which I appreciate. I'm going to leave you to it. I'll be here if you have any questions. I'll see you on the other side. Oh, hang on. Before we do that, we got to pick the other three winners from Noctrix, and then we'll do yours afterwards. Cassidy Pedram, Mary Wiley, Aaron Diaz. You're all getting a $50 Amazon gift card, which we will email to you. Sar, take it away.
Thank you. And today I'm going to talk about the clinical gap that still exists between the home sleep test and the traditional full PSG running in the lab, and how emerging technologies such as Dormotech can help bridge that gap. Okay, and PSG is considered the gold standard, and for a good reason. It captured the full physiological picture, providing full signals such as EEG, EOG, EMG for sleep stages, all the respiratory signals, airflow, effort, oxygen saturation, snoring, and many more. And what you're seeing here on the screen is actually the DormoVision X device that was designed to capture all of this physiological richness, but provide the same signal within the comfortable of the patient on bed independently. And the environment indeed really matter, because if you think about it, and if you compare it to the PSG in-lab system. So the patient have to sleep in an uncomfortable, unfamiliar environment with the technician monitoring and interacting. Occasionally, a lot of wires involved, and typically it's a single line test. Whereas here, using the DermoVision HST, patient can run the test in their own environment, multiple nights, and this is provide a much more a stress-free environment, comfortable and easy to make with multiple nights. And this extensive data and signals is especially important when you want to look beyond the and not just ask what if there is an abnormality that is occurring, and start asking what is the process that we are looking at, moving beyond the simple AHI that we are often drawn to. So the literature is already full information saying that we should not be concentrated on summarized matrices and per event comparisons, but we should look much further to patients with the same AHI. Exactly the same AHI can represent very different cases, showing different physiological burden, different pathophysiology, and most importantly, potentially very different treatment trajectory. So it is important to to explore all of those signals to provide a full picture. So in the next few slides, I am going to show you some real example. Since Dormotech became integrated in clinical across the board, we began observing some pattern along our collaborators from the clinic. And I want to share some insights that we gather based on real patient examples to show you what we can see when we move beyond the limitation of the conventional sleep test and start observing multiple signals across the sleep test. So, yeah, taking a while to load. One of the main concepts we were drawn to is the OSA, the obstructive sleep apnea endotype. And as I said, two patients presenting the same AHI can represent very different cases. And one of the ways to characterize them is to separate the component per patient within this disorder into vectors and into what's really characterize the disorder. So, and the main parts known in the literature are the loop gain, muscle responsiveness, erosibility, and airway collapsibility. And each patient can be represented with the interaction between those factors. And if we'll jump just into an example showing exactly that. So here we have two patients with the same AHI, and let's characterize them using this model. So if we'll zoom in on patient A, yes, I hope you can see it, I'm not sure, but if we'll zoom in, so what you can see here is that the patient is a classic case of OSA associated with arousal. Yeah, okay, great, thank you. Associated with arousals, you can see the cortical arousal presented here on the summarized EEG signal, and this is the airflow, and down below, this is the oxygen saturation value and summation of the ventilation versus the chemical drive. I will touch on that shortly. So you can see cortical arousal occurring shortly and very consistently after each respiratory event over here. Yes, and it's also associated with drop in oxygen, but the events are relatively short. The desaturation is mild, and the chemical drive doesn't really get to accumulate into the more severe area, but this is because the brain keep interrupting this event due to the arousals. And still this patient have a very disturbed sleep, even though the oxygen saturation is not reaching a very low area most of the time. Whereas if we zoom in to patient B, again, the same AHI. I hope it's zooming in. I'm not sure if you can see it. So here we have a patient with much more prolonged events and more severe drop in the saturation. The chemical drive over here indeed builds up and builds up, but the ventilation comes in later in this process. If you look on the summary plot here, you can see that the event keep occurring and the ventilation and the recovery from the event takes a long time. Now, it is important to differentiate between those cases because, for example, if we take a look at the treatment option for patient A, CPAP will not be a good option. He will not be able to tolerate the CPAP since he has such a low arousal threshold. Everything will trigger the arousal, and his sleep would not be maintained. He will not be able to tolerate the device. Alternative treatments such as mandibular positional therapy and other aids, also surgical option, will be better adjusted for him, whereas patient B can be a good candidate for CPAP. And he can benefit a lot. He can maintain the good sleep without arousal, and he probably will benefit it mostly because it will prevent the desaturation, but still enable him to maintain good sleep. And another area where this characterization and differentiation between the two, between different conditions is important is when observing obstructive versus central event. And a special case which makes it even more important is the chain stop breathing. It's a subtype, a specific case of breathing related disorder characterized by circular patterns of crescendo decrescendo events, and also a lack of effort during those events. And over here, I'm just showing you the approach we develop in order to automatically score and detect those events in order to be able to flag them to the physician reviewing the report. And the reason it is so important to identify those patients and differentiate them from other is because those patients are associated with very high risk of heart failure and cardiac event and cardiac instability. And usually they are referred to cardiac inspection on top of the sleep test. And it's not just about not being fitted for CPAP and maybe BPAP. It's also about preventing other complication, not only sleep related. And the third case I would like to review with you is related to positional monitoring. So we all know, and for many years, that one of the major modulator of sleep is the position, and specifically supine position during sleep can trigger and make the event much more severe. And this has been known for many years, and for that reason, this is very commonly included in sleep tests. But it's usually measured based on the thorax signal location, indicating the body position, and indeed providing an important information. Is this the full story? I'm not sure. So what I'm showing you here is another example patient. So dermal vision is routinely monitored and using, in addition to the body position, additional signal for head orientation, continuously streaming alongside the position signal. And what is shown here, and in this patient example, so when he is lying supine, you can see worse over here in red, this is severe events, and the severe is worsened during the supine position. And this is the classic case of a positional dependent OSA. As we know it, there is no surprise here. But if we closely examine this patient with the head orientation signal, we can see that there is variability in the severity. Even when he is still lying in supine condition, the body hasn't moved. But when the head is tilted upward, the severity of the event is much lower. You can see a very low value. Again, he is still supine, but the head is tilted upward. Whereas when the head is shifting to the side, the severity of the event increases again. So just by modifying the head orientation, without changing the body position, we can still modulate the severity of the event. And if you think about it, there is a huge potential here because we are already treating positional OSA by adjusting the body position. Think of what we can do if we add to that the head position. And with that, I know I have only a few more minutes left. So with that, I will summarize that what I've just shown is just the tip of the iceberg. And we mainly concentrated on the respiratory aspect, whereas the neurological and other condition offer much more and bigger opportunity that we can explore. And with the AI area, this is offer even greater opportunity in this field. I'm a big believer in sleep being a window to the brain, enabling us to see some patterns that are usually camouflaged during the noisy wakefulness and become obvious during sleep. And I think there is a lot to be discovered, and it's within our reach. We only use a fraction of the information that is out there in the sleep test. We can do much more. If you think about it, a while ago, it was considered outside the scope of sleep medicine to be exploring early marker of neurodegeneration, whereas nowadays no one talks about Parkinson's disease without mentioning RBD. There is no reason why it shouldn't be the same with other diseases, including those that have already been explored in the literature, and there is markers that have been proven to be valuable and exist within the sleep test. I think we are approaching an era in which sleep medicine is going to be much more enriched, multiple dimensional, and we can harness the use of all signals available to us. And with that, I will end, and I'll be happy to take more questions.
Thank you for your presentation, Sar. I have up on the screen the book a demo link. And is there an easy way for people, if they want to get in touch with the company directly, even if they have questions about the product?
Yeah, absolutely. So I will put my email address in the chat. You can also find here contact information. You're welcome to send it to us. We are also going to be in the conference in Baltimore, so you're welcome to stop by our booth, see the product, try it on, and contact us there. We also have LinkedIn and a website, and you're welcome to look for us. I will put some details in the chat later on.
That's great. Now, will you be personally in Baltimore for the meeting?
I personally will not be able to be there, but we have a full member, a lot of team members that is going to attend there. We're going to have a nice booth, and you can always contact me personally after the lecture.
Well, I was hoping to be there. A question just came in from JT. Can we do bilateral EMG for PLMS?
Bilateral EMG, yes, we can. I've only presented the HST version, which is widely used to give a higher availability for the test, but we also have additional version used for in-lab testing. This is basically the same device, but we also add some external unit to it, and we do have the ability to measure those. And whenever someone bring up such a request from account, and we see that there is a growing need, we always love to bring up more and develop new option for the contact. So shortly, yes, we do have the option to add external units, and we always like to include new addition as well.
Excellent. We are right up against our time. Let's announce the winners. Thank you very much for being here, Sar. Thank you for the great presentation. You can see Dormotech at Sleep 2026 in Baltimore. Here are the three winners from Dormotech: Luke Latanya, Samantha Swanstrom Anderson, and Shelly Carlson. So we'll get those out to you guys. And our winner for the Philadelphia Sleep Conference, March 19th, next year, 2027, it'll be our 15th anniversary. Stacy Gerards, you are the winner for that. We got one more question while you're here. Are there any data in the teen and pediatric population, Sar?
Yeah, absolutely. So the product is approved for pediatric use as well as for the adults. We do have FDA documents and all the study conducted there, and we are hoping to publish soon also in a peer-reviewed journal. So yeah, it is widely used for pediatric use.
Good. And if you're wondering, for those watching, that gentleman that popped in was Kyle Hunter from Dormotech. He was behind the scenes here. So that was him. I'm sure you can see him at the sleep meeting. So
yeah, he's definitely going to be there.
good. We're going to wrap it up right now. Thanks everyone for being here. All the winners, you will get everything. This was a great product demo live. We appreciate Dormotech, Noctrix, and Persante. Great information, quick hits. That's what we like. And we'll see you on the next one. Thanks, everybody. Bye-bye.